Welcome to Pulse&Pressors, where critical care gets crystal clear. Today we're diving into the intra-aortic balloon pump, or IABP, a device that stood the test of time in cardiac support. The balloon pump is a mechanical circulatory assist device that sits in the descending thoracic aorta. It doesn't replace the heart. It works with it, inflating and deflating in sync with each cardiac cycle. The goal is simple but vital: unload the left ventricle, reduce myocardial oxygen demand, and enhance coronary perfusion. Here's how it works. During diastole, the balloon inflates, pushing blood backward toward the coronaries and forward toward the brain. Then, just before systole, it deflates, reducing afterload and helping the left ventricle eject blood with less effort. This rhythmic counterpulsation improves perfusion and oxygen supply while easing the heart's workload. Insertion is typically percutaneous through the femoral artery, advanced through the external iliac artery, through the common iliac artery, and into the descending aorta. The balloon tip sits about 2 centimeters below the left subclavian artery, confirmed on fluoroscopy or chest X-ray. If the balloon sits too high, it can occlude the subclavian. Too low, it risks the renal arteries. So positioning precision is critical, and so is meticulous monitoring of distal pulses and urine output. Indications include cardiogenic shock, post-cardiac surgery, low output states, refractory ischemia, and mechanical complications of myocardial infarction, such as papillary rupture or ventricular septal defect. It's also used as a bridge to recovery or escalation, buying time until more advanced support is available. But there are contraindications, like aortic dissection, significant aortic regurgitation, and severe peripheral arterial disease. In those cases, the risks outweigh the benefits. The hemodynamic effects of balloon pump are consistent. It reduces afterload, enhances coronary perfusion, and modestly raises cardiac output, often just enough to stabilize perfusion and prevent end organ injury. The hemodynamic fingerprint of a balloon pump is subtle but meaningful: improved coronary perfusion, lower wall stress, and a modest bump in cardiac output, often the difference between instability and survival. The augmented diastolic peak should rise above the native systolic. That's the balloon inflating in diastole and boosting coronary perfusion. The assisted systolic pressure will then drop below the unassisted beat. That's afterload reduction, meaning the LV is ejecting against less resistance. Your mean arterial pressure should remain steady or slightly higher, showing improved overall perfusion stability. In short, a high diastolic peak, low assisted systole, and a smooth MAP confirm that your balloon is perfectly timed and effectively unloading the ventricle. Once the balloon is in, bedside management becomes critical. The patient should remain flat or with the head of bed less than 30 degrees to avoid kinking or migration. Check distal pulses, radial, DPs, and PTs, every hour, and assess limb color, warmth, and cap refill. Loss of pulse or coolness means ischemia until proven otherwise. A drop in urine output means the balloon migrated and renal arteries are affected. Similarly, migrating too high can occlude the subclavian artery and affect left radial and ulnar pulses. Maintain heparin anticoagulation, secure the line, and use the log roll method for repositioning. Never stop the balloon for more than 30 minutes. Thrombosis can develop rapidly. Weaning should be gradual, moving from 1-to-1 support to 1-to-2, and eventually 1-to-3, ensuring stability in mean arterial pressure, cardiac index, and urine output before removal. Do not leave the patient on 1-to-3 support for prolonged periods, as thrombosis can develop. Briefly move to 1-to-3 and assess discontinuation suitability. Complications include limb ischemia, balloon rupture with helium embolism, bleeding, infection, thrombocytopenia, and aortic injury. If blood appears in the helium line, the balloon has ruptured. Stop the pump immediately. Troubleshooting relies on waveform interpretation. If augmentation disappears, check timing or trigger. If deflation is late, afterload increases. Deflate earlier. If inflation is premature, systolic pressure rises. Delay inflation slightly. Timing errors turn a helpful device into a harmful one. Ultimately, the IABP remains one of the simplest, safest, and most effective tools for left ventricular support, especially when time is short and resources are limited. It's a bridge device, not a destination, but in the right patient, it can make all the difference between survival and decline. This is Pulse&Pressors, providing daily education on the marvels of the human body.